As a vascular surgeon, I think a lot of people don't understand what I do versus what you'll hear from Dr. Cameron a little later in the day. Vascular surgeons, just to sort of inform you, are traditionally associated with a couple conditions. One is varicose veins, and the other one is blockages of the arteries. In fact, vascular surgeons also do quite a bit in terms of aneurysms. And the aneurysms that the vascular surgeons address, the arterial events that vascular surgeons address, happen largely outside the area of the chest. In my particular area, that could include anything from about the left subclavian artery, which is what goes up to supply the left shoulder, extending all the way down to the tips of the toes, and from sort of the base of the neck all the way to the top of the head. So the various arteries that get associated with vascular surgeons are things like carotid arteries and aortas in the abdomen and the descending portion within the chest, and then the iliac vessels down in the pelvis. There are some femoral vessels in the groin and the thighs, and then the popliteal vessels, which run down behind the knee. In fact, in Loeys-Dietz syndrome, we appreciate that there are arterial changes in really all of those areas. And although the aortic root tends to be the focus of many of the discussions because it really is the preeminent vascular manifestation, we can also see changes in these other blood vessels. And what I have here is a talk that I had given a couple years ago to the Society for Vascular Surgery, and to get back to some earlier comments about frustration with providers, I think that getting the word out to the vascular surgery service is going to be part of the effort here in terms of some summer projects I have with summer students. So we're going to try and make this new syndrome a little better understood. What we know about the condition is what you've already heard from Dr. Dietz. I won't belabor many of these points, but obviously the real key area of the TGF-beta receptor and the effects on the signaling of that molecule throughout the entire body. The characteristic triad we know is the tortuosity and aneurysm, the hypoterelism, and the craniofacial abnormalities, but in fact there are lots of other manifestations of the disease that are also quite relevant to quality of life for patients with Loeys-Dietz syndrome. And of course there are two types, one slightly more malignant than the other, but both of which really require very expert management to have good outcomes. So what we did back a couple years ago was to take the population of patients that had imaging at Hopkins, and that was at that time about 68 patients. I can tell you that just yesterday Gretchen emailed me another 57 for whom we have really good imaging at Hopkins on, and I've got a summer student who's working on those throughout the next couple months to update some of the numbers I'm going to show you here and give a better sense about what to expect with Loeys-Dietz syndrome in terms of the blood vessels outside the heart and how they may or may not behave. And again, looking at radiologic evaluations, we did look at the clinical evaluations, what's happening to the patients and what's happened to them over time, and then sort of some outcomes concerning the non-aortic root surgeries, peripheral vascular surgeries. This is data that was accrued mostly from 2 years ago, and as was implied earlier by Dr. Dietz, many of the patients who came to Hopkins at the outset of the discovery of the Loeys-Dietz syndrome tended to be those who had more severe clinical manifestations, and I think we've gained some perspective regarding the syndrome in the last couple of years by seeing other patients who aren't quite as severely affected, and seeing other patients who are having aortic events later in life versus the scarier ones that we see in the children's and teens. Again, the aortic root aneurysm is really the central portion of the phenotype and what is where many of the imaging studies have been directed. This is a general distribution of what we see in terms of the arterial lesions in the Loeys-Dietz syndrome. This was, again, going back to those original CAT scans. And I want to preface this by also commenting that, again, most of those early CAT scans tended to be patients who are at the higher end of the severity range. And I think the next series that we look at here this summer with the other 57 is probably going to imply a little bit wider distribution of arterial lesions, as well as having age of onset probably be not quite as early as the original descriptions. But we do see in many patients, and these are the carotid and the little vertebral arteries, are those little ones there. Those are the ones sort of at the shoulders, around the neck. We do see carotid tortuosity. We do see vertebral and subclavian tortuosity in a slightly smaller amount. It looks a little bit like this on a CAT scan. And this is actually a CAT scan of a fellow who's about 57 years old. I don't see the group in the audience, but you can appreciate the multiple hairpin turns coming through the carotids here. It's harder to see the vertebral arteries because the vertebral arteries run inside a bony canal along the spine, and you can appreciate maybe right there a little loop of the artery sort of coming out between the interface between the two vertebral bodies. But the carotid tortuosity is quite common, and vascular surgeons have been looking at hairpin turns in carotid arteries for a long time. Sometimes we see these in older patients just as a consequence of aging of the blood vessels, and we appreciate patients to develop these hairpin turns, and the question always becomes, well, can those hairpin turns become a risk for stroke? And again, in an older group of patients who seem to develop these, that is 65, 70, 80 years old, we haven't really appreciated that to be a problem. The next area we see, and this was just looking at the CAT scans, was the aortic root aneurysms. Descending thoracic aortic aneurysms around 35%, and the descending thoracic aorta is this portion of the aorta within the chest. This is the aortic root, this is the ascending aorta, the arch of the aorta, and then this is a descending thoracic aorta. And the descending thoracic aorta then turns into the abdominal aorta as it crosses the diaphragm. The diaphragm's what are the bellows that allow your lungs to move air in and out. So the descending thoracic aorta is about 1/3 of patients, and it tends to be that we see on the CAT scans a little bit of plumpness of the descending thoracic aorta right as it leaves past the subclavian artery. And in many patients that can actually be physiologic. You can see in some patients, even in people who are getting CAT scans who have no related connective tissue disorders, you can see a little bit of dilation of the descending thoracic aorta there, and I hesitate to say that it might be this high. It might actually be a little bit lower. I think time will tell about whether that number holds up. But the descending thoracic aorta is an operation that is sometimes done by cardiac surgeons and sometimes done by vascular surgeons. The significant difference on the descending thoracic aorta versus that of the ascending aorta is we tend to worry more about the risk for paraplegia because the arterial circulation to the spinal cord comes off somewhere within the chest in most patients. So this is a very scary complication that we really work very hard to mitigate in almost all the patients that we operate on. Luckily, the absolute risk for a paraplegia event, if one had to come to a descending thoracic aortic surgery, is really measured in about 1 or 2% of patients. Abdominal aortic aneurysm we see less commonly. This is the abdominal aorta here. Tortuosity is actually quite uncommon. The 7% of patients that we had in that series who had tortuosity were certainly some of the more severely affected people with the Loeys-Dietz syndrome. So I think as we appreciate the next group of patients who are probably going to be more in the middle of the spectrum, I think some of these numbers may drop. I have certainly operated on patients with abdominal aortic aneurysms, and their aortas have been very, very tortuous, but I can tell you that most of those operations are occurring in people in their 40s and 50s. They're not occurring in the childhood age groups. We've had some experience in the descending thoracic aorta for the for the children, but almost always that's in the setting of a dissection. So the dissection sort of starts the cascade of several operations that then come thereafter. And this is a little bit of what I'm talking about the tortuosity. Normally, the aorta comes down in a straight line coming down along the spine, and you can appreciate here how it's making this little chicane through the area. This is what tortuosity is. CAT scans are better at helping us with this, and I think that as we have this better group of imaging coming along in the next couple months, we'll get a better sense of this. As vascular surgeons, we tend to be quite comfortable with the concept of this center line of the aorta. So if I took a line and drew it down the aorta and made it, using a software package, sort of follow the line of the middle of that blood vessel, that would give me a center line measurement. And as you might guess, as a child grows, well, the centerline measurement will grow as the aorta grows too, but it will be informative if we can pick up if the centerline growth is increasing faster than what I call the axial growth, the total growth of the child. And that might be an index that we could use in the future to monitor how effectively losartan and other medications are addressing the disorder that may be a way to capture that data without putting someone through a blood test for TGF-beta or the like. So there may be some useful surrogates for how the blood vessels are behaving based upon the CAT scans in the future. And that'll be something that we'll be working on in the next few months to hopefully get that out in the literature, again, to really not only inform all of you, but also to inform some of the surgeons that you guys might cross paths with who, again, may not be the expert in the room when you're sitting in their office. Surgical repairs, again, you can see the age here tends to be older, that we're seeing repairs outside the aortic root. Some of the common themes to particularly aneurysms involving the entire thoracic aorta and abdominal, which are these TAAAs, the thoracic and abdominal aortic aneurysms, versus here, which is just the thoracic aortic aneurysm, is that those tend to be patients who suffered a dissection. And this is really where we come back to the key pillar of monitoring these patients, which is to keep an eye on the aortic root. Because once the aortic root unravels with a dissection, the rest of the aorta is really put at risk. And following thereafter, other patients had to have other operations to address those portions. And this particular patient here died of a brain aneurysm, which was quite a surprise because she had imaging to look at that, and this patient did fine with that operation, but then was found to have had a ruptured abdominal aortic aneurysm, was sort of lost to follow-up. And this very unfortunate person had a series of operations, and it was all related to a dissection. So again, the real key here is to really monitor the aorta very closely. I think once we get into doing repairs, particularly if the initial inciting event had been a dissection, it does really put the patient at risk for developing other operations down the road. Happily, we're a lot better at those operations in the 2000, in the past decade than we were back in the 80s. But I think the concept that multiple repairs may be required is something that we tend to certainly cross when we get into the dissections. We have had some patients, particularly, for example, this fellow here had an abdominal aneurysm, again in his 50s. I fixed a popliteal aneurysm, and he's got his other operation waiting to fill that box. It's his other popliteal aneurysm. He just doesn't want to do it right now. So, we have to keep an eye on the patients, and there certainly is the need for regular imaging. Whether that imaging is done yearly or every other year is really more patient dependent. So I want to just close with really the key implications, which is that obviously we know here in this room this is an aortic aneurysm syndrome. I think a lot of my compatriots in vascular surgery and probably know a lot less. We're going to work on that for you. I think that there is a general misunderstanding, and this is something that we highlighted last year in our vascular annual meeting, where several thousand vascular surgeons were. We had a paper on the Ehlers-Danlos syndrome. And there is a very common misconception that when someone comes in with an arterial problem at a very young age, they're almost immediately assigned to the diagnosis of vascular Ehlers-Danlos syndrome. And that's a real injustice, because the surgical management of this disorder is quite frightening versus the surgical management of the Loeys-Dietz, which is actually pretty straightforward, and I think the operations have a lot of refinement. So I think as we highlight this difference between the group and continue to do so in some of the upcoming research projects, that I think will also help to inform people and make sure the right diagnosis lands with the right patient. Because you certainly would not want to consider a very aggressive strategy of operating in a prophylactic fashion in the vascular Ehlers-Danlos, but in the Loeys-Dietz, operating in a prophylactic fashion is a very safe paradigm. So I think that our initial operative experience outside the heart, to put it broadly, is very encouraging. But I think long-term follow-up, particularly by looking at this next set of CAT scans to get a sense about how fast the aortas are growing, how fast the tortuosity seems to be improving, might give us some very useful ways to help judge how medical therapy is going for the patients.